ये बाहर जो Good morning, everyone. Today's CME will be having first Dr. Girinivasan presenting on his experience of the US Traveling Fellowship. Giri sir, I believe that you've joined.
Yes, they are. Am I audible?
Yes, sir, you are audible. Sir,
Yeah.
David sir, can we start, sir? So may we start?
Good morning, all. Giri, good morning. You can start your presentation.
Good morning, sir. Yes, sir. So my screen sharing is not working. Just I will rejoin again, sir.
Okay.
Good morning, sir. Am I audible, sir?
Yes, Giri, your presentation is also visible. Please start.
Thank you, sir. Thank you. Good morning, everyone. I thank David sir, Santosh sir, and Shyam sir for giving me this opportunity. I will just present my experience in US from June 15 to October 10. I hope it's useful for the current fellows. I'll be sharing the points which I felt was clinically important in the places that I visited. The journey started with Isaka's first. I was selected for the Young Research Investigator Award. That's the reason I was planning for the US trip. Since it was being held in Boston, I was applying for the other centers in Boston to do short-term fellowships there. So Isaka's Congress was great. I had the opportunity to meet some of the eminent people in the field. And the first stop was at the Massachusetts General Hospital with Dr. Bassam El Hassan. I did a 1-week clinical observership program at the Harvard. I was exposed to some crazy cases there. Dr. Bassam is known for tendon transfers and complex scapular surgeries. I'm showing some of the cases and pictures that I felt was clinically relevant. This may not be new for the fellows. So the first case was gap non-union of clavicle, which was fixed with an allograft reconstruction, which we don't see quite often in our countries because of the non-availability of allograft. And this is a malunited medial end of clavicle fracture for which interposition arthroplasty of the sternoclavicular joint was done using an semitendinosus allograft. And this one another case which was shoulder arthrodesis was done some 20 years back, for which the arthrodesis takedown and reverse shoulder arthroplasty was done with almost 4 tendon transfers, pedicle pec major transfer for the deltoid, latissimus dorsi transfer for the external rotation, and teres major transfer for internal rotation and anterior instability. And this again one more complex reverse case which was being revised for the third time with instability. And for this, because of the huge bone loss, some allograft prosthetic complex reconstruction was done along with the tendon transfer of lower trapezius and anterior capsular reconstruction using an allograft. This again a case of cuff arthropathy for which latissimus dorsi transfer was done anteriorly. So in small shoulders and chronic dislocations, Dr. Bassam had the practice of pec minor release and conjoint tendon release routinely for all cases. The difference I found in reverse shoulder arthroplasty with Dr. Bassam was that the other in most centers and in most videos that we see online, the RSA is being balanced with by increasing the implant sizes when there is instability after trial reduction, but he was balancing it with tendon transfers. And some of he had a separate classification for scapular dyskinesis with which he was managing each cases. And this is a case where which was called neurogenic thoracic outlet syndrome. The diagnosis itself was quite new for me. We don't often name those cases as neurogenic thoracic outlet syndrome, but I felt that we do see cases like this in our OPDs with normal cervical spine, MRI, or a mild disc protrusion in the cervical spine, but the patient is having radiating pain to the arm, which we often manage conservatively with the exercises. He designated them as the neurogenic thoracic outlet syndrome and had a trial of Botox injection to the pectoralis minor. If it was working, he then went on to do a pec minor release with the brachial plexus neurolysis arthroscopically. And he was quite convenient in going to the medial side of coracoid in the arthroscope, whereas we were taught that the medial side is always a suicide. The next stop was New England Baptist Hospital. Sorry, I didn't tell how I got into the absorption program with Harvard. I think how to apply will be the most important question for all the fellows. I was just randomly messaging big surgeons in and around Boston. Since I was going to Issakas in Boston, so I messaged them taking the email ID from the internet, from the official websites, and attaching my CV and telling them that I'm coming for Issakas and I needed to do some clinical observership or short-term fellowships if available. So Dr. Bassam was kind enough to reply. I applied to various surgeons in Harvard and to the New England Baptist Hospital as well. So Dr. Bassam was kind enough to reply. He told that Harvard has only 1 week observership program. There is no short-term fellowship, and was able to get into it. We need not pay anything for the observership as such. And the next one is the New England Baptist Hospital. I contacted the shoulder chief there through email. I was also in touch with him on LinkedIn. LinkedIn I found was very helpful in socializing with the big people. So he was also kind enough to reply. He told that the New England Baptist Hospital has a visiting international fellowship program where I can spend up to 3 months. But the thing was the expense should be taken care of by ourselves. So it was quite expensive in Boston. I thought of limiting my visiting fellowship to 2 months. So I was here from July and August. So the cases are not as crazy as Dr. Bassam lesson. These are the small tips and tricks that I learned that I'm going to share with you. So the first thing is cuff repair in lateral position. We were in autumn we are exposed to only beacher position. Lateral position was something new. I was with Dr. Alan Curtis, who's the current honor president. He does only cuff repairs. So it was very surprising to see surgeons in US who do only one surgery a lifetime. Like this guy does only cuff repair throughout his practice, and I saw one more guy who does only reverse shoulder throughout his practice. So he does a two-portal cuff repair for routine moderately retracted tears, and three portals if subscapularis is involved. It was new for me to see the bursal-sided repair of the subscapularis. This is a view from the posterior portal showing the anchor to subscapularis on the lesser tuberosity. And the concept of biceps, philosophy of biceps was entirely new for me in the US. They preserve biceps. Most of the surgeons that I visited, except for Dr. Nikhil Verma, they had the idea to preserve the biceps. They moved on from tenotomy or tenodesis of biceps in all cases to preserving the biceps till more than 50% of the fibers are involved. So most of them are of the view that biceps is now a valuable tendon which can be used in younger patients for procedures like dynamic anterior stabilization, and in older patients for revision cuff repairs when the primary repair fails. Even if they do tenodesis, Alan Curtis does in situ tenodesis, which is according to the SCOI teaching, where they don't do tenotomy of the intra-articular part. They just do tenodesis of the biceps in the groove without doing an intra-articular tenotomy. They are just stabilizing the biceps with an anchor. And the subpectoral tenodesis was reserved for very young and active patients who had a groove instability in particular. And distal clavicular excision, I've seen a few cases, but the technique there was entirely new. They're just going into the lateral lateral AC joint and doing the distal clavicle excision rather than going through the anterior portal. And for massive cuff repairs at the New England Baptist Hospital, they were using partial repair with biceps SCR, which we do routinely, but they were adding a balloon spacer to it. It was quite costly, and I don't think we can do it in India here. And I was exposed to good amount of total shoulder replacements and reverse shoulder replacements. In total shoulder replacements, one interesting concept that I was found was they were augmenting the subscapularis repair with BMAC, which was just taken from the proximal humerus. I didn't knew that we can extract that amount of bone marrow from the proximal humerus. They are using it to centrifuge and forming a clot and then putting it in between the repaired subscapularis. And I had exposure to only few reverse shoulder cases, two reverse shoulders when I was doing fellowship in Athon, but there are large number of reverse shoulders going on there, and was exposed to some revisions and primaries, but I don't know how much will be able to use them in India, as the reverse shoulder cases are very low. The next stop after August 31st was the IASCS Traveling Fellowship 2023. So I got lucky that this fellowship came right after my visiting fellowship at the New England Baptist Hospital. So I think Munish had already enlisted on how this selection process for this fellowship happens. So first they put out a pamphlet on their LinkedIn site as well as the Twitter page. So after which we should send our CV to them. So after that they shortlist some 10 candidates and mail them 10 to 12. I don't know the exact number, 10 to 12 candidates, and mail them back, and they conduct some personal interviews, and finally they select 3 fellows. So as a part of this fellowship, this fellowship was in the West Coast this year and in the East Coast last year, where Munish traveled. So in the West Coast, we visited 5 centers and had some good experience in each of the centers. So the first center was Chicago with Dr. Nikhil Verma. I will again share some interesting points that I found interesting with my very little knowledge in shoulder at the beginning of my career. So the Dr. Nikhil Verma uses 5 o'clock and 7 o'clock portals for all routine Bancott repairs. The 5 o'clock portal goes through the subscapularis, and the 7 o'clock portal is just like the Remplissage portal that we use. So using these portals, he tells helps him prevent skywarp of the anchors during banker repair, which I found in my initial one or two cases as a important complication, skiving off of the anchors as we try to put them on the face of at the 5 o'clock or the 4 o'clock position in the banker repair. And some other cases that I saw was again he was using balloon spaces very often, and he showed us his technique of distal biceps repair and UCL reconstruction in the elbow. The next stop was Los Angeles. We had a small cadaveric training on how to use Arthrex reverse shoulder prosthesis, which had full wedge and half wedge augmentations. And here the consultant, Dr. Rishi Garg, was doing band cord repair in beach chair position, which was quite new for us. And he was also doing reverse shoulders in a fully supine position with the neuro monitoring in case of in complex cases where he felt that axillary nerve should be monitored. And again in Orange County, we were with two surgeons, Dr. Hafiz Kazam and Dr. Hafiz Kasam. These cases were by him. Some of the complex revision RSAs. The first one was revised for the fifth time, and again we saw how to use an allograft prosthetic complex. Allograft prosthetic complex is nothing but a long segment of proximal humerus along, which is seen in the picture here, along with the prosthesis. So the complex is fixed to the native bone using the plates. And again some revision of the infected cases. And in San Diego, we were with Dr. Anshu Singh. We saw some interesting cases apart from reverse shoulders. The first one is the use of jigs to cut the distal tibia bone graft for reconstruction of the glenoid bone loss, similar to Latarjet, but using the distal tibia allograft. And we saw scapulopexy. I also saw this surgery with Dr. Bassam Al Hassan. Scapulopexy is nothing but it sounded very weird and crazy to me. It's using a semitendinous allograft and fixing the lower inferior pole of clavicle to the ninth rib in case of scapular dyskinesis. And we again saw arthroscopic pec minor release and arthroscopic brachial plexus neurolysis. And we saw a case of again the sternoclavicular joint reconstruction here as well. And the next stop was in Dallas with Dr. Sumant Krishnan. Again, his concept and view of cuff repair and reverse shoulder arthroplasty was entirely new, and he does cuff repair in V-chair position using the exact same portals that we use in Ortho 1 four portal technique. He tells it's very important to have all the four portals to have adequate visualization of the cuff, just like we do in Ortho 1. But he uses transosseous cuff repair all the time. The device is quite similar to the one that we have in Orthon, but the mechanism is slightly different as they are from different companies. He uses the one from Tornier, and we have the one from which was developed by Brett Sanders. Ours is reusable, but his is disposable. He was kind enough to give 2 or 3 the transosseous instruments to us to carry home back. He told we can use it after ethylene oxide sterilization. So he does scapular, what he calls a scapular decompression in all the cuff repairs, where he removes the medial end of the acromion instead of the clavicle. He tells that this prevents the destabilization of the clavicle. So he removes just 1 to 2 mm of the distal clavicle and then removes the rest from the acromion. And his RSAs, all his RSAs, he does using the antero-superior approach rather than the routine deltopectoral approach for the primary cases. And he propagates bio-RSA in reverse shoulder arthroplasty. And this picture in the right is one interesting way of how to make shoulder spacers. So he uses retrograde tibiotalar fusion nail, so which is held in a slanting position using 2 Armin AV, and he makes a cement spacer using the bulb that we use in BP apparatus. And the final stop was in Scottsdale. Here we saw all varieties of instability. The first picture is posterior drive-through sign, the posterior instability where posterior capsular raphe was done, which is not new, but was interesting to see. The second was a repair of a huge bony Bancott lesion with a double row, which I had not seen. This is the first time that I saw. And the middle picture was the repair of a slap lesion, which type 3 bucket angle slap lesion, which was associated with the Bancott lesion. We also saw a case where there was a huge Hill-Sachs lesion, like 40% of the head was involved, where distal tibia allograft, sorry, the proximal humerus allograft was used to reconstruct the humeral head. And he had a peculiar practice of isolating and securing the axillary nerve in each case of reverse shoulder that he does. Apart from these educational surgical tips, we also were taken to labs during this traveling fellowship, where this is in Chicago, where we was taken to 3D motion analysis lab and biomechanical lab there. We were also taken to the tribology lab. And this is in Los Angeles. The group picture, the instrument behind us in the group picture is a shoulder biomechanical model. This is a famous shoulder biomechanical model where the important surgical procedures like superior capsular reconstruction were tested. And we are also exposed to an upcoming concept called insert glenoid, which is coming up in total shoulder replacements, where the glenoid is just inserted into the glenoid component is just inserted into the native glenoid rather than keeping it over. So they tell this is going to prevent the glenoid wear and revolutionize the total shoulder arthroplasty as such. And in Orange County, the surgeon Hafiz Kasam, so he uses different processes for different patients. Like he uses Exatec for a patient. He has his own algorithms. Like if a patient is in old age, he tells that the Grammont model is doing better and it's better to go with the older designs. And if it's a younger patient, he goes with the newer late life design. So he had this idea of personalizing processes for each patient that he has. So normally he on a routine day, he uses 4 different processes for a single for different patients in a single day, which was quite new for us. And this is in University of California, Irvine, where we were exposed to some molecular research that's going on. The research was about the nerve endings and how they respond after cuff tear, and how the muscle responds after a nerve injury, like an axillary nerve palsy. These are all very interesting for us to note. So that's the end of my presentation. I hope it was useful.
Thanks, Giri. I think one take-home point from here is try to preserve the biceps most of the time, because if in case we end up with the revision case, the biceps can be used as a valuable tool for the biceps superior capsular reconstruction. That's one. Second thing is, luckily, we are not coming across these sort of complex revision cases in shoulder replacements or real weird cases where you use the other pectoralis minor and all those grafts. That is very interesting.
Thank you, sir.
Giri, Santosh, what was the thing which you were doing under the water with the tibial nail? I didn't understand.
Sir, that for infected reverse shoulder replacement, they showed
Cement
us
spacer.
yes,
Okay,
sir,
okay.
making a simple technique to make a cement spacer. They were using this BP apparatus of bulb. They were cutting it into half to make the head of the humerus, and then they were using the retrograde tibial nail as a stem cell.
Oh, okay. Thank you.
Found it interesting. That's why I just did.
Thanks, Giri. Thanks for sharing.
Thank you, sir.
I'm just wondering that, these are the academic kind of things. And apart from that, you having been exposed to the Indian scenario, then US for more than 4-5 months. What really struck you, and what do you think that you can introduce into your practice? Not exactly the technology, but otherwise. And how are you imparting to your students? Can you tell us quickly, please?
Yes, sir. So outpatient clinics were one thing which were very similar to ortho. They had New England Baptist had almost a similar setup, and even Harvard had a similar setup to ortho. But the way they explain patients was quite different. But the patients there were demanding. Like one of the surgeons that I was with was Dr. Andrew Java. So he was very keen. Like before the patient meets him, the patient goes through a video demonstration of what problems they have and what are the possible options, and he also gives them a booklet on how many surgeries of that particular procedure that he has that he has done so far, and what are the complication rates. And most of the surgeons there are very particular with the numbers. Like they exactly tell how much percentage of failure is associated with different cuff repairs, and how much percentage of failure they have seen in the past years. They explain to the patients in a very detailed manner for at least half an hour. So that thing I thought I can implement in my practice, like having the video demonstration. Patients when they come to the surgeon, they exactly know what is going to be done, and then the surgeon again explains, and they explain all the complications. But we are already doing that. But this one thing, I thought that it was more elaborate in the United States. And the other thing is research. Like few of the centers that we visited during the traveling fellowship, and even the New England Baptist Hospital, these are all fully private setups. But even these surgeons, they get attached to some medical colleges and teaching centers nearby. They get access to these cadaver labs, and they make sure that they do some research and show some weekly progress. So that was also very interesting for me, sir.
So
And
you're
the
able
other thing,
to.
sorry, sir.
So you're able to implement all this in where you're working or students?
So not right now, sir. Slowly I will try to implement it, sir. The main thing there is like to get into orthopedics, to get into institutes like Harvard. Even before entering into the program, people are having at least 30 research papers. Like one of the undergraduates in Dr. Bassam Ellason's team, he was third year undergrad, but he was having 28 papers in orthopedics published. So that was very surprising. So they need not strain much because the undergrads are buzzing the consultants, and they want to do something in orthopedic research. So the consultants have to just distribute the work. So that culture is not there in India. Maybe in future it might come up. The other thing that I found was the work-life balance there. Like they work 5 days a week, and they have a good family life and good social time in the remaining 2 days. That was nice to see, sir.
All right, thank you.
Thank you, sir.
Ashik, you can start your presentation.
So am I audible? Hello, sir.
Yes, yes.
Okay, sir. Starting. Good morning, everyone. Topic I'll be discussing today will be shoulder dyskinesia, and These are the contents and the order in which I would like to present them. So it's a vast topic. Shoulder dyskinesia is a vast topic, and we'll straight away get into it. Starting off with the introduction, the scapula fulfills many roles to facilitate optimal function of the shoulder. Normal function of the shoulder involves the scapula that can be properly aligned in multiple planes of motion of the upper extremity. Scapular dyskinesis, meaning abnormal motion of the scapula during shoulder movement, is a clinical finding commonly encountered by shoulder surgeons. It is best considered an impairment of optimal shoulder function. As such, it may be the underlying cause or the accompanying result of many forms of shoulder pain and dysfunction. This class will look at the causes and treatment options for this indicator of shoulder pathology and aims to provide an overview of the management of the disorders of the scapula. Coming to the basic sciences, scapula is a key component of the kinematic chain. It is an important role in glenohumeral rhythm. Role in efficiency and efficacy of the limb also is a crucial part played by the scapula. The glenohumeral joint, GHJ, is the gateway between the axial skeleton and the upper limb, so acting as the link. The glenoid fossa and the humeral head operate in complex synergistic fashion to permit the multiplanar movements of the joint. The balance between the joint stability and the freedom of movement is regulated by static and dynamic factors. The anterior surface of the scapula has a concave surface which serves as the attachment for subscapularis and serratus anterior. The coracoid process originates from the superolateral anterior surface as a finger-like projection where the pec minor, biceps brachii, short head, and the coracobrachialis attach. The posterior surface contains the bony structures of the spine, acromion, supraspinatus fossa, infraspinous fossa. The spine and the acromion contain the attachment of the trapezius and the deltoid, whereas the supraspinous and infraspinous fossae serves as the attachment for the supraspinatus and the infraspinatus respectively. The inferolateral posterior surface also provides attachment for the teres minor, teres major, and the lat dorsi. Now, this is the structure that is the foundation of it all. The entire kinesis of the scapula is to present the glenoid and the acromion in the most optimal orientation so that the entire upper limb that anchors itself onto the glenoid is able to attain its maximum range of motion to its potential. Mechanical roles played by the scapula, it supports the arm, protects the cervicoaxillary canal, acts as a means of force transfer. Biomechanical roles, it acts as a center of rotation for the humerus, anchor of the humerus to the thoracic wall. It prevents impingement by coordinating its own movement with that of the humerus, and it helps transmit forces from the core of the body to the arm. For attaining the complete range of motion of the shoulder and orienting the glenoid in the most optimal position upon which the upper limb can move, the entirety of the scapula needs to move in multiplanar directions as seen here in the diagram. These are some of the movements of the scapula, better represented by images. The elevation by the upper trapezius and the levator scapulae, the depression by the lower trapezius, the adduction or retraction by the middle trapezius and the rhomboids, the abduction or protraction by the serratus anterior, the upward rotation by the upper trapezius, the downward rotation by the rhomboids and the lower trapezius. The rhythm. Analysis of the key shoulder movements like flexion and abduction has provided a comprehensive appreciation of the movement stages involved. For these seamless and well-coordinated movements to occur, the glenohumeral joint and the scapulothoracic articulation move in harmony, just like an orchestra. Hence the term the glenohumeral rhythm. So what is this rhythm? Inman et al. Found that the movements of the shoulder complex don't occur in isolation, but it is a well-coordinated set of movements that occur silently in the background unconsciously. For example, in the first 30 degrees of abduction of the humerus of the shoulder joint, the primary objective of the scapula is to find a position of stability to optimize the power of these movements. In some cases, the scapula would remain static, or in the other cases, it would translate medially or laterally to assist the glenohumeral motion, to be ready to assist the shoulder in further abduction. It is important to note that 0 to 30 degrees, the scapula plays no role in abduction. It just sets up its position to support the further abduction. So this phase is called the setting phase of the scapula. Further abduction till 90 degrees, the range of motion is carried out in a fixed ratio, that is 2:1. So this 2:1 means that for every 2 degree of movement for the humerus, there is 1 degree of movement for the scapula. So for reaching abduction of 90, from 30 degrees that is already achieved, you have 60 degrees more to go. So you divide that into 3 parts. 2 parts go to the humerus, 1 part go to the scapula. So that is this part. 30 degrees already achieved. 2 parts of 60, that is 40 degrees, goes to the humerus and 20 degrees goes to the scapula. Similarly, if you want to abduct till 180 degrees, you follow the same rule of 2:1. So from 90 to 180, you have another 90 degrees. So you divide that into 3 parts of 30 each. 2 parts of 30, that is 60 degrees, go to the humerus. 1 part of 30, that is 30 degrees, goes to the scapula. So this is how 30 plus 40 plus 60, that is 130, and 150, 180. 180 degrees of abduction has been achieved. Recent literature have suggested that less variable patterns of scapular movement, with the key component being upward rotation and followed by posterior tilt and external rotation. Research has highlighted that the upper and lower trapezius, along with the serratus anterior, are the muscles that mostly affect scapular movement and cause dyskinesia. So now, since we have a normal idea of the normal movements, let's dive into the abnormal. Scapular dyskinesis is a non-specific response to a painful shoulder condition, rather than a specific response to a certain glenohumeral pathology. It has multiple causative factors, and it has been defined as an abnormal static scapular position and or dynamic scapular motion characterized by medial border prominence, inferior angle prominence, or a rapid downward rotation during arm lowering. Like everything in orthopedics, if there is a problem, we have classified it. So in this also, it has been classified by Kibler et al. In 2002 in this paper, and it has been classified into different categories. Type 1, at rest, the inferior medial scapular border may be prominent dorsally. During arm motion, the inferior angle of the lower tip tilts dorsally backwards, and the upper part tilts ventrally forwards. So the plane of rotation is the horizontal plane. So this part moves front and this part moves back. In type 2, at rest, the entire medial border of the scapula may be prominent, commonly called as winging. During arm motion, the medial scapular border tilts dorsally off of the thorax, causing the winging. The axis of the rotation is vertical in the frontal plane. In type 3, at rest, the superior border of the scapula may be elevated, and the scapula can also be anteriorly displaced. During arm motion, a shoulder shrug initiates movement without significant winging of the scapula occurring. The axis of this motion occurs in the sagittal plane. Causes of scapular dyskinesia. It can arise due to a plethora of causes, such as shoulder-related, neck-related, posture-related, or other specific injuries. Shoulder-related injuries are AC instability, shoulder impingement, rotator cuff injuries, glenoid radial injuries, clavicle fracture, and neurological conditions. Dyskinesis can alter the roles of the scapula during scapular-humeral rhythm and may be due to alterations in bony stabilizers, muscle activation patterns, or lack of strength in the dynamic stabilizers. This can be due to inappropriate timing, where the muscle is activated too fast or too slow, or due to inappropriate strength of contraction, where the muscle is activated too strongly or too weakly. Neck-related problems can be classified as mechanical neck pain, which can be further classified into divided as degenerative changes in the joints or fatigue or imbalance of the muscles. Cervical root-related problems can be further divided into nerve root compression and nerve root avulsions. Athletes and IT professionals are more susceptible to changes brought about due to abnormal posture. Depending on their support or profession, they develop core muscle imbalances that alter spinal curvatures and soft tissue tensions. Specific injuries have been discussed in detail in many literatures supporting labral injuries, impingement, rotator cuff injuries, AC joint injuries commonly seen in American football players, and clavicle fractures. All these things have one thing in common. Either they create the movement of scapula to be very painful, or they create extreme stiffness such that the entire kinetic chain is disturbed and the kinesis of the scapula has been altered. The commonest causative mechanism of dyskinesis have a soft tissue component involving either intrinsic muscle pathology or inflexibility or inhibition of the normal muscle activation. Decreased flexibility of either the short head of biceps or pec minor have been shown to create anterior tilt and protraction of the scapula as a result of their pull on the coracoid. The pec minor has been shown to be shortened in length in patients with impingement. This tight muscle creates a position of scapular protraction at rest and does not allow the scapula posterior tilt or external rotation upon arm motion, predisposing patients to impingement syndrome. Strength and activation of the serratus anterior are reduced in cases of impingement and shoulder pain. This can cause a loss of posterior tilt and upward rotation of the scapula, leading to scapular dyskinesis. So what are the effects of scapular dyskinesis? Creates a protracted scapula, not at all optimal for shoulder function. Decreases the subacromial space. It increases the incidence of impingement and rotator cuff compression, thereby reducing the rotator cuff power. Epidemiology. A lifetime risk of 40 to 60% is there and commonly seen with athletes with overhead motion like swimmers, volleyball players, handball, tennis players, etc. Long duration users of personal computers also have this condition due to postural abnormalities. Now, this is an interesting paper that compared the athletic group in overhead versus non-overhead group as well. They found that they hypothesized that the overhead athletes would demonstrate a significantly greater reported prevalence of scapular dyskinesis compared with non-overhead athletes. Overhead athletes, as a result, did have a greater reported prevalence of 61% compared to non-overhead of 33%. However, what was surprising was that the 33% also was significantly higher than what was expected at the time of starting with the research. So it shows how prevalent shoulder scapular dyskinesis is as a problem. Clinical evaluation. Direct observation, manually assisted movements, and assessment of surrounding structures. Starting with direct observation, basically the examiner makes the patient stand and perform active movements in flexion or abduction while the examiner observes for winging, early elevation, rapid downward rotation, and shoulder shrugging. The findings are noted as a yes or no answer and followed with a description of the best performance. Manually assisted movements of scapula, there are two main tests, the SAT, the scapular assistance test, and the SRT, that is a scapular retraction test. SAT involves the examiner pushing the inferior border towards outwards and upwards, basically aiding or helping the scapula in doing its normal function, which it should have independently done. So you're helping the scapula in going through the normal kinesis. This test assesses how different the pain is perceived without assistance and with assistance. In a positive test, the pain is reduced, while in a negative, the pain persists. And it is usually positive in patients with a painful arc or a shoulder impingement. What is the significance? If symptoms of impingement are diminished or eliminated by this maneuver, then rehabilitation of the scapular stabilizing muscles is likely to help alleviate the symptoms. Scapular retraction test. Now, this is just like a basic empty can test that we do. First step is to do the empty can where isometric upward force is exerted by the patient's arm onto the examiner's arm. The initial part of the test is done without stabilizing the scapula. Now, the pain score, VAS, is marked. The second step of this test is by putting the examiner's opposite hand on top of the scapula to stabilize it. And the same exercise is redone. If there is an increase in the isometric force exerted by the patient on the examiner's arm and the pain has subsided after stabilizing the scapula, it is considered a positive test. And physiotherapy and management protocols will help in improving the condition. Third test is the lateral scapular slide test. It's basically like the Adam test in spine. You mark out the inferior medial pole of both the scapula and you compare the difference in the pole position in three different positions. Arm by the side, arm at the hip, and arm in 90-degree abduction. Cutoff is 1.5 centimeters on either side. It's 1.5 centimeters more than the normal side. If the affected side moves more than 1.5 centimeter, it's considered as a positive test. An essential part of the scapular examination is evaluation of the shoulder pathology or injury that could be causative or exacerbated by the concurrent presence of scapular dyskinesis. Rotator cuff injury, labral stability, internal impingement should all be sought out because these are the assessment of the surrounding structures, thoracic, cervical spondylosis, anything of that that can lead to pain and difficulty. Coming to the investigations, many investigations are present like the nerve conduction tests that may be of value if a specific traumatic precipitant causes injury to the long thoracic nerve, dorsal scapular nerve, spinal accessory nerve. EMG, electromyography studies can be can help in identifying injury and the potential for recovery in periscapular muscles. X-rays can help us identify bony abnormalities like the clavicle or hooked acromion or the AC joint injury. MRI, it can help us delineate the muscle injury and locate the soft tissue lesion that is causing scapular dyskinesis. MRA, it can help in identifying any concomitant labral injuries. Coming to the most important part, the treatment. The mainstay of treatment of scapular dyskinesia is physiotherapy to relieve the symptoms associated with inflexibility or trigger points and to re-establish muscle strength and activation patterns. Dyskinesis can often be caused by muscle inhibition, caused by soft tissue related pathologies such as labral injury, internal impingement, rotator cuff pathology, or hard bony issues like AC separations. In these instances, the surgical problem should be addressed prior to commencing physiotherapy to correct the dyskinesis. It also plays an important role. One of the main objectives should be to optimize the kinetic chain from cervical spine, thoracic spine to the shoulder. Now, rehab protocol involves active conscious control, strength and control for daily activities, and a focus on the three important muscles, that is the trapezius, serratus anterior, and the rhomboids. Average duration of treatment for recovery should be around 12 weeks. However, the paper states that for high-intensive individuals like volleyball players and all, treatment may take longer, around 3 months also. So what is this active conscious control? So scapular musculature requires reorientation in order to re-engage the correct pattern of activation. So we have to reorientate the muscles to re-engage in the correct order also. So for example, if the inferior part of the trapezius can be oriented with a scapular orientation exercise that promotes targeted re-engagement of the muscle under tactile feedback from the other limb. So this picture shows the tactile feedback from the other limb. This is the affected limb, and this is the contralateral unaffected limb. So notice where the hand is placed. He's placed it on the coracoid. So as per the scapula is made to move, or the patient moves the scapula, he is getting instant feedback from the movement of the coracoid that is feeling from the contralateral arm. That is the active conscious control. And strength and control for daily activities is also a main concept at this stage of treatment. It can involve open chain exercises and closed chain exercises. Open chain exercises like the lawnmower exercise, the lateral row exercise, the robbery exercise, and the inferior glide exercise are very important in this treatment. The main objective of closed chain exercises will be to promote the awareness of the joint proprioception and coordination of the rotator cuff muscles. Moreover, muscle strength can be achieved by engaging the deficient muscles in isolation while minimizing the activity of the stronger ones. Now, whatever the exercise regimen chosen, the main objective of conservative management of SD cases aims to restore the scapular retraction, posterior tilt, and external rotation. It can be done by flexibility exercise to reduce the scapular stiffness and scapular stabilization exercise to optimize scapular kinematics. The traction on scapular posture can be reduced by performing exercises that increase muscle flexibility. Stretching exercises with the shoulder in horizontal abduction at 90 degrees and 150 degrees of elevation have been demonstrated to be useful in increasing pec minor flexibility and the external rotation and posterior tilt of the scapula during forward elevation. Scapular stabilization exercise based on stretching and strengthening aim to improve muscle strength and joint position sense. The serratus anterior and the trapezius muscles act as the most important scapular stabilizers. The serratus anterior plays an essential role in determining scapular external rotation and posterior tilt, and lower trapezius helps to stabilize the scapular position. These are some of the exercises that scapular stabilization exercises include. They are the open kinetic chain exercises, including push-ups on a stable or unstable surface, lawnmower exercise, and resisted scapular retraction. This is another serratus anterior exercise, that is, you're making the patient lie supine, giving him the dumbbells and telling him to protract the scapula or push forward in the same position. This is a serratus anterior push-ups. That is basically you're holding in the push-up position and asking the patient to protract the scapula or stretch out the serratus anterior. Another useful exercise is the rotating upward shrug that stimulates the upper and the lower part of the trapezius also. A relatively new concept is kinesiotaping. So it is especially useful in type 2 SD, where the kinesiotaping over the upper and lower trapezius muscles may rebalance the scapular muscles, increasing the upward scapular rotation. So what about the neck? We studied that the neck also contributes to scapular dyskinesia. So patients with SD can also suffer from neck pain, and a randomized control trial was done, showed that global postural re-education, instead of just stretching exercises, improves patients' quality of life and pain, emphasizing the role that posture plays on SD and neck pain. So what if exercises fail? When a conservative approach fails or joint internal damages occur, example, AC separation, glenohumeral injuries, detachment of the scapular muscles, surgical treatment should be taken into consideration without hesitation. Conditions like AC and CC ligament disruption changes the scapula and clavicular kinematics. And only through surgical reconstruction is the restoration of biomechanical stability even possible. So, what to do in these cases of secondary SD, where the primary problem is a surgical problem that has to be dealt with in a surgery basis, and scapular dyskinesia is a secondary factor due to that. It isn't clear if treatment should focus on the cause first or the altered kinematics first. Furthermore, just removing the cause surgically does not necessarily mean that the scapular dyskinesia will also resolve on its own. Also, correcting scapular dyskinesia does not always solve that the associated problem which has to be managed surgically will also resolve. So in those cases, a holistic approach managing all issues at hand, utilizing both surgical management for the primary and conservative management for the secondary SD must be taken. To summarize, we've come across the scapular rhythm, the shoulder pathology, pathomechanics we've dealt with, and the effects of scapular dyskinesia like the protracted scapula, and epidemiology, comparing the normal population and the athletes, and within the athletes, the overhead athletes and the non-overhead athletes. The clinical evaluation using the SAT, SRT, LSST, investigations including the X-ray, MRI, EMG, NCV, and etc. And the treatment, including the physio exercises, the surgical management, and the holistic approach and its importance. Thank you, sir.
Ashik, what is static scapular dyskinesis and dynamic?
The static will be dynamic will be during the arm motion, sir. Especially in type 2, where the movement is causing the instability and decrease in power transmission from the rotator cuff. That is what I understood from static and dynamic, sir.
So how do you identify static and how do you identify dynamic? Dynamic, yes, you put through range of motion. Yeah.
Yes, sir.
What about static?
Static will be when the shoulder is examined during the initial phase without the arm by the side, sir. For example, if there is winging when during isometric exercises without movement, if there is active movement of the scapula, there is winging. If there is serratus anterior when you're pushing the wall, that will be all static, no, sir. Dynamic.
But you're activating the muscle, isn't it?
Yes, sir.
Even when you're trying to push the wall, you're activating the muscle. So without activating the muscle, you should elicit the scapular winging. The best way to do is ask the patient to bend forward.
Okay.
And try to no need to activate any of the shoulder. Just bend forward. When he gradually bends forward, there will be elevation of the scapula, which you can see from the front. So you have to stand in front of the patient, tell him to bend forward, and then you see that the medial border just pops up. So that's the first indication that there is the indication that the serratus is not functioning well. And another thing is the pectoralis minor is overpowering the serratus anterior. So these are the most important cases which do not yield well to conservative management as per Laurent Lafosse. And those are the conditions which may end up going in for arthroscopic pectoralis minor release. I mean, I understand that Lafosse and his team are quite aggressive in surgical options, but just keep it in mind that if these patients do not do well with rehabilitation, then the culprit is pectoralis minor. You can strengthen the serratus anterior, but the pectoralis minor power is overpowering the serratus anterior, which cannot be treated conservatively with the rehabilitation. So in such cases, a pec minor release will aid in strengthening the serratus anterior.
Any benefit in opting for pec minor stretching exercises, sir? Some papers do mention that
you do it. Yeah, correct. See, only if that fails, only if that modality of treatment fails over a period of 3 months and you still find that the patient is having winging and the pain is not subsiding with day-to-day activities, then we can do a arthroscopic pectoralis minor release along with serratus anterior strengthening.
Sure, sir. Sure, sir. So shall I stop sharing?
Yes, we can start the next presentation. Santosh.
Sure.
Now, by the way, your presentation was about scapular dyskinesis, not dyskinesia.
Oh, yes, sir.
I hope you know the difference between both.
Yes, sir. Yes, sir. You told me, sir.
Yeah.
Good morning, sir. Is my slide visible, sir?
Yes, Santosh, please proceed.
Sir?
Start, Santosh.
Good morning, everyone. Today I'm going to talk on biomechanics of throwing. So, what is throwing mechanism? Throwing mechanism is a study of mechanical aspects of principle involved in excessive and accurate effective throw in various sports activity. So, what is the art of precise throwing? Throws are fundamentally action in sports like baseball, cricket, javelin, shot puts, and more. The precise throws requires a combination of skill, strength, and precision coordination of movements. While throwing a javelin, all footwork, trunk, hand, shoulder, everything has to be in what? Then why to study throwing mechanism? Two things to be noted in this. One is optimize the performance and prevent injury prevention. How will you optimize the performance? By analyzing the mechanics helps the athletes and coaches refine techniques for more accurate and powerful throws. How will you prevent injuries? By knowledge of proper mechanics aid in reducing the risk of overuse of the shoulder commonly associated with throwing sports. So there are several type of throwing techniques used in various sports. The image shows is the overarm throws. In this type of throws, the arm is brought back and then forward in an arc over the head before releasing an object. Either it's be a ball or a javelin, whatever it may be. Then the first image shows the underarm throw. This throw, the arm swings below the shoulder level during the throw. The releasing point is typically closer to the ground. Example is a softball pitching. And second image is the sidearm throw. In this type of throw, the arm is extended to the sides rather than over or under the shoulder. So the releasing point is lower than in an overarm throw. So example, the sidearm throw pitching in baseball or discus throw. Next is sling. In this type of sling, the object is either a stone or a bullet is whirled around the sling before being released. This is used in Asian warfare and in nowadays in barely modern sling competitions. Now, the first image is the hammer throw. In this, the athlete swings a heavy or spherical object, the hammer, around in a circular motion before releasing it. And second is shot put. The athlete holds a heavy spherical object and push it away from their body to gain a distance. And third is javelin throw. The athletes run in a long and slender with a spear, that is a javelin, and propels it as far as possible. This all three involved in a track field event where athletes are compete to throw for a longer distance. Coming to dots, dot is a player throws a small weighted dots at a circular targeting point and aim to score a point by hitting the specific area. So in that, it's a competitive game, indoor game, where it has been used in indoor pub games and all. Next is axe throw. It involves in throwing an axe at a target, typically from a specified distance. And next is boomerang throw. A participant throw a boomerang in a way that it returns back to the thrower. These two things are a recreational activity at present. Coming to the important talk of this is typical phases involved in throwing action. First is the wind up phase. In this phase begins the initial movement of lead leg and culminates with elevation of its higher point. During this phase, the lower extremities prepare a stable base energy transferred via center of gravity over to the back leg, and it propels a maximum momentum in this subsequent phase. So maximum energy from the lower body is being transferred in this phase. So risk of shoulder injury is relatively low during this phase. The early cocking. Next is the early cock phase. In this phase begins with the lead leg reaches its maximum height and ends when the lead foot contacts the pitching. So in this phase, the trunk stability is critically as strider requires a balance control. In this early cocking phase, the most important you have to be the trunk balance and control. So the deltoid, supraspinatus, infraspinatus, and muscles gets activated in the late portion of this phase to external rotate the shoulder. So next is the late cocking phase. This phase occurs between the lead foot contact and the point of maximum external rotation of the shoulder, throwing shoulder. So in this phase, the scapula brought into position of retraction and elbow flex, and humerus undergo additional abduction and extreme external rotation. So in this phase, the shoulder approaches the maximum external rotation, whereas subscapularis, pectoralis major, and latissimus dorsi are eccentrically contract and applying a stable anterior force to the glenohumeral joint. So hyperexternal rotation at glenohumeral joint allows the accelerating force to act for a longer distance of throw. Next is the acceleration phase. This phase is defined as a time between the maximum of external rotation of shoulder and the ball release. The scapula protracts as the humerus undergo horizontal adduction and interrotation. In this phase, the subscapularis muscle, pectoralis major, and latissimus dorsi reaches maximum activity during this phase and produces an internal rotation of the humerus. And next is the deceleration phase, occurs between the ball release and humeral interrotation and elbow extension. This is often considered the most violent and dangerous phase of pitching motion, as it results in greatest point loading during this throwing. During this deceleration phase, the excessive distraction and shear force are placed on the glenohumeral joint. So any energy not imparted through the ball is dispelled through this shoulder, resulting in significant eccentric load on the posterior rotator cuff musculature. During this, deceleration, there is also mock biceps and brachialis activity to decelerate the rapid extended elbow. Coming to the last is the follow-up through phase. In this phase, is proceeded with body continue to move forward with the arm until motion has been ceased. I will revise once again. In wind up, the maximum force exert from the lower body to the trunk, where essential center of gravity of the back leg is generated most of the movement. In early cocking phase is that the maximum height, the lead height where the lead leg exerted and the lead leg foot comes in contact. Then late cocking is the maximum of hyper external rotation of the joint, and acceleration phase is where the maximum acceleration to the shoulder releasing the ball. And third will be deceleration phase. In this phase, there will be excessive distraction and shear forces are placed on the glenohumeral joint. Then phases involved in bowling actions. The first will be the starting position, where the bowler begins in a stationary position and stand at the top of the run-up. The second is run-up and the bowling grip. In the run-up, the bowler takes a series of steps to build up the momentum before reaching the crease. Where bowling grip, the bowler holds the cricket ball in their hand with a specific grip based on the type of delivery they intend to bowl, either fast, spin, or swing. The loading phase, as the bowler approaches the crease, they initiate the loading phase. In this phase involves in preparatory movement to generate the power for the delivery. So next it will be the front foot landing. The bowler plants their front foot on the ground, typically just before the bowling crease. This marks the transition from the running up to the delivery stride. And coming to the delivery stride, the bowler's back foot follows through and the front leg straighten out. The strider towards the batsman is the key phase, is generating power and accuracy. Coming to the cocking phase, the bowler starts the cocking phase where the bowling arm is brought back and begins to externally rotate and storing energy for the delivery. And next is acceleration phase. In this phase involved in rapid acceleration of bowling arm towards the target, where the muscles around the shoulder, arm, and upper body plays a crucial role in generating the speed. And the releasing phase, the ball is released from the hand at a specific point in bowling action. In this position of the wrist and fingers at its movement determines a type of delivery. Example, the seam or spin or swing, whatever delivery they are released. Next is the follow through phase. After release, the bowler body continues in a motion. A controlled follow through helps to dissipate excessive generation and maintains the balance. Then will be the recovery phase. The bowler's transition from followed back to an upright position leads to the next delivery for the field action. So this is the video simple way of plotting the movements or for the bowlers in the throwing action. Next is, so in a basketball throwing, there are 3 phases. One is preparation phase, execution phase, and follow through phase. In preparation phase, there are stance, position, and dips. These 3 things comes in preparation phase, whereas the alignment and the release comes in executive phase and follow through phase. So in stance, in preparation, stance phase is the initial phase of your feet and body before begins to shoot position. It is important to have a balanced and stable stance to optimize the accuracy and power. The position phase refers to the positioning of arm, hand, and fingers onto the basketball. A proper grip and hand placement are crucial for controlling and consistent in your shoot. Next is a dip. A dip is a slight downward movement of the ball prior to standing and shooting motion, and it generates movement on rhythm for the shot. So coming to the execution phase, that is alignment and release. In this alignment is that the phase involves in aligning your shoot arm, elbow, and wrist to the basket, and proper alignment ensure the ball travels in a straight pathway towards the target. Second is the release. In this point, which you release the ball using a flick of your wrist to apply a back spin of a smooth shoot. This release should be a fluid and consistent, with a ball leaving your finger smoothly without any jerky movements. Coming to follow through phase. In this phase is a continuation of shooting phase. After the ball is released, it is allowed. It is involving extending the full arm towards the basket with your wrist and fingers pointing towards the rim. So now coming to kinetic chain involving overhead pitching. This consists of linked motion of hip, trunk, and with ballistic motion of the upper extremity to propel the ball. All the phase are intricately coupled, resulting in efficient generation and transfer of energy from body into the arm and ultimately the handball. The leg and the trunk serves as the main force of generating a kinetic energy, and the chain, the scapula, is facilitating the energy transfer distal to the hand. Kibber and Sander, in their study, they said that 20% of decrease in kinetic energy delivered from the hip and the trunk to the arm requires 34% increase the rotational velocity of the shoulder to impart the same amount of force to the hand. So improvement in the velocity is also reduced in kinetic contribution of the shoulder to produce a top velocity. So in this, mainly the scapula is the key transferring energy distal to the ball. So any scapular dysfunction prohibits the optimum energy transfer. So transfer of power from the point of plant foot to the tip of throwing hand is processed that relies on strength, flexibility, and range of movement at the end ball. So the time between the front foot contact and the ball release will be 0.14 seconds. So coming to the kinetics of scapular position, the scapular rotation undergoes both upward and downward rotation during this phase of throwing motion. This movement is critical for stabilizing the shoulder and enabling the proper arm position. Whereas protraction and retraction involves the scapula away from the spine, and this motion plays a role in controlling the motion of shoulder girdle. And elevation and depression refers to the upward movement of the scapula. This contributes to overall stability and position of the shoulder. Then in this, the serratus anterior activation is crucial for stabilizing the scapula against the ribcage during throwing motion, and it helps in maintaining the proper alignment and positioning the scapula. Coming to the muscles activation in throwing from legs and the core, these muscles provide a foundation support and power of throwing. They generate the initial force that is transferred through the body. Example, in a baseball pitcher, the leg generates the maximum power through push of the mount. In this, the calf muscle, the gastrocnemius soleus, plays an important role in kinetic chain of propulsion, whereas the quadriceps extension action acts as a stimulant for energy transfer from the leg to the upper body and kick off the throwing phase. And the hamstrings, those hamstring aid in stabilizing the knee and transition from the wind up to acceleration phase during the throwing. The fourth one will be the adductors. The adductors helps the pitchers to maintain balance and control during the throwing. So this is around the leg muscle. Coming to the core, in core muscles or rectus abdominis, obliquus and transverse abdominis stabilize the spine, and a strong core maintains a good posture alignment, which is necessary for producing maximum power and accuracy. And then will be the shoulder muscles. The shoulder is the muscles in the around the shoulders, like deltoid, rotator cuffs, are heavily involved in or controlling the propelled arm. Next will be the arm muscles. They involve in flexors and extensors for the releasing and controlling the ball and maintaining the precision. And wrist and hand muscles. These muscles are used in controlling the fine tuning of ball during release, allows precision and direction of the object. So in precision fine tuning, muscles in throwing of baseball for scapula supporters, rhomboid and serratus anterior stabilize the scapula and limit excessive movement and allow for efficient force transmission, whereas rotators of hip, the piriformis and external rotator as well contributes in rotation movements of the throwing, and their participation involves in overall mechanism of kinetic chain. And flexors of fingers contributes in grip strength and baseball control. A firm grip is essential for keep controlling in pitch type. Coming to coordination throwing, the sequential activation, timing and rhythm, and balance and stability and fine controls are important. In sequential activation, the muscles activate a specific generate smooth and powerful motion, whereas timing and rhythm, proper coordination ensure the different muscle group works togetherly throughout the phase of throwing. Whereas in balance and stability, it maintains essential control and accurate throwing, and it is involved in coordinate various muscle groups to prevent over rotation or loss of control. In fine control, the coordination of muscle group, specifically involved in hand wrist, allows a precise control over the release of direction of balls. So joint mechanism involved in throwings, all the joint from hip to ankle involved in both involved in throwing for stable and a precise control in action. So the importance of proper technique in throwings are accuracy and precision. Next is maximum power and distance, reducing the risk of energy. Then consistency should be there, and efficient movement of throwing, adaptability and longevity in the sports, and performance in optimization, and leads to competitive advantages and coachability and skill development. And coming to case study, a talented high school athlete, baseball pitchers, has been experiencing a recurrent shoulder pain after a game. He knows for his impressive fastball, but recently he noticed a decrease in pitch speed and accuracy. On biomechanical analysis upon examination, it is observed that the shoulder external rotation during the cocking phase is excessive, putting undue stress on the shoulder. What might be the reason? Can anyone answer this?
Yeah, any of the
Shoulder
fellows?
excessive shoulder external rotation shows that there is limited scapular retraction and decrease in pitch, probably because the core stability is not up to the mark.
Anyone? Because the excessive external rotation is classically seen in pitchers, but that needs to be compensated by another movement, isn't it? So you need to think.
We know inner rotation deficit.
Yeah, correct. So who said that?
Sir, I'm Govind.
Govind, yeah. So can you tell me what is good?
Due to the excessive external rotation, the internal rotation will be compensated. The total arc of the movement will be changed, sir. So that the external rotation is increased and the internal rotation will be deficient, sir.
Total arc will be maintained.
It will be maintained, sir.
Compensatory restriction or reduction in internal rotation.
Yes, sir.
Yeah, correct. Yeah, proceed, Santosh.
So how will you compensate the proper technique? So implicating the corrective throwing program, focus on improving the core strength and scapula control plays and can help in reducing the excessive shoulder movement. This not only help in align the pain, but also enhance the longevity of pitching career. Second is promising javelin thrower constantly falls short of her personal best despite of vigorous training. Her coach suspects a release technique might be a contributing factor. On biomechanical analysis, through a video analysis, it observed that the thrower releasing point is not aligned with the intent trajectory. Can anyone answer for this one?
The release
Proceed. I think it's because of weak core balance, I guess. Proceed, Santosh.
This is due to hand position during release is also inconsistent, and that might affect the javelin flight path. So while throwing, the releasing point might be inconsistent, and the video analysis shows. So how will you do this thing? Ensuring consistent releasing point and hand position, which leads to more accurate and powerful throws in this case. Next, case 3 is the competitive shot putter has plateaued in his performance despite having a stronger upper body strength, but he is struggling to generate despite of distance in his throw. And biomechanical analysis shows upon evaluation, it reveals that the lower body is not efficiently transferring the power to its upper body. Can anyone answer this one?
The kinetic change seems to be affected. The lower limb is not acting as a link chain in the kinetic chain that it's supposed to be acting it as. So it's not transferring the power from the lower body to the upper body, and the kinetic chain is only half working.
Yes, correct.
So how will you improve in this one? So refine lower body mechanics, involve the precision footwork and effective weight transfer. He can unlock the greater potential in his shot put throws. So take home message is proper technique need to be known for the precise for throwing, and sequential activation and transfer of momentum from lower body to the upper body. Mainly the key factor in contributing throw is arm speed, releasing point and accuracy. They generate higher energy speed and releasing the object. Then timing and coordination of different body segments, and video analysis to identify and correct the faults in throwing motion. Thank you, sir.
Thank you, Santosh. In overhead throwing biomechanics, there are only two games which are given importance to, and in Western scenario, it is baseball pitching, and in Indian scenario, it is javelin. We cannot compare bowling to pitching because the biomechanics is quite different. So javelin can be compared to the pitching in baseball. And two important phases which are prone to cause injury to the shoulder is the late cocking phase, where there is excessive external rotation causing a torsional stress on the longus of biceps attachment. So this extra physiological range has to go through some damage to the existing normal physiology. So the unfortunate structure here is the longus of biceps. Apart from that, during the follow-up, that is the deceleration phase, after the excessive external rotation is compensated, the shoulder goes through translation in the axial plane, that is posterior translation. That causes further injury to the posterior capsule, which stretches, and because of the stretch, it undergoes a lot of contraction. So that is a basic physiology behind the posterior capsular contracture that is seen in patients with overhead throwing athletes. Because of the extra physiological load, it undergoes a compensatory contracture, and that produces further injury, which may be in the form of a posterior labral tear, or it can be in the form of an internal impingement. So if at all you come across a patient or a young athlete with overhead throwing activity, then always focus on three things. One is first check on the scapulohumeral rhythm along with the core strength. Second is check for internal rotation deficit, which can be seen with posterior capsular contracture, which can be done with the various clinical examinations that are available. And third most important thing is injury to the longus of biceps. And in the last class, we have discussed about how to diagnose the longus of biceps injury with three tests. One is O'Brien's, another one is dynamic labral shear test, and another one is direct labral palpation, direct biceps longus of biceps groove palpation. So if these three things are positive, then probably there is a high chance for a biceps labral complex injury. So keep in mind the biomechanics of shoulder is different in a pitcher, it is different in a bowler, it is different in a javelin thrower. In pitching and javelin, the shoulder is subjected to a lot of injury, whereas in bowling, of course, the shoulder is injured, but the primary complex that is involved in bowling is the abdominal muscles. So if you have a weak core muscles, abdominal muscles, then your bowling swing and the bowling alignment, everything gets deferred, and you're prone for injury. And one classical example is our previous ex-Indian player and CSK player, Lakshmipati Balaji. You see, his career ended because of rectus abdominis tear, because of faulty biomechanics, and he never returned back to active games. Yeah, I guess maybe in future our gold medalist, Olympic gold medalist Neeraj Chopra may also come with a shoulder pathology, because he is every event he is pushing his limits. So we need to watch out for already existing injury in his shoulder.
The speakers, they put up a good show, but often I've seen that they don't examine the patient properly. They don't strip the patient. They don't ask them to remove the shirt. It's very important to examine the patient properly. Thank you.
You can start, Praveen.
Morning, everyone. So, yes, sir. So I'll be quickly talking about on-track and off-track lesions, since it's been extensively covered in the previous few sessions. I'll just quickly run through what does the track concept mean, and the current concepts, new evolutions with regards to track concept. It was put forward by et al. In 2007. So basically, it is the track that the humeral head takes along the glenoid through its range of movement in the abductor external rotation position. So it gradually shifts from the inferior medial part of the humeral head to the superolateral part of the posterior portion of humeral head. This zone of contact throughout this moment is called the glenoid track. So how do you define it radiographically? So this is defined as a distance from the medialmost margin of contact of the humeral onto the glenoid and the medialmost point of insertion of the rotator cuff. With further cadaveric studies, Omori et al. In 2013 established that the glenoid track, that is the path the glenoid humeral head takes along glenoid, is roughly equal to 83% of the glenoid width. But this point is being very heavily contested with the current studies, which they say that it might be even much less than that. So basically, there should be an intact glenoid track for the shoulder ROM to occur for a stable shoulder ROM. With regards to bipolar lesions, that is lesion with the humeral head as well as in the glenoid, more than the size of the lesions, the dynamic interaction of the dynamic interaction as in like the position of the Hill-Sachs defect and the width of the glenoid defect and the interplay between these has more significance rather than just an intact glenoid bone for stability of the shoulder. So as you can see here, the glenoid width can be calculated by taking a line perpendicular to the longitudinal axis, and roughly 83% of the greatest glenoid width corresponds to the glenoid track. So as you know, previously the concept was whether it was an engaging or a non-engaging lesion. This was a concept put forward by Burkhardt and De Beer in 2000s. So how they went about this concept is that the arthroscopically examining the joint, looking for engagement of the shoulder and arthroscopically in the abductor and external rotation position. So why move on to this concept or track concept? So as you can see, this is a live dynamic examination under arthroscopy to look for engaging or non-engaging lesions based on which interpretations are made. However, with the glenoid track concept, it can be done arthroscopically also, but more importantly, it can be done with CT scan effectively to determine whether lesions are on track or off track. And also, the problem with this technique, as described initial description Burkhardt et al., it is done in a shoulder without an repair done, meaning in a ligament in a lax shoulder, it is subject to the extremes of position and look for engagement, which will invariably happen since there is no inherent support for the joint anteriorly. So this dynamic intra-op assessment done prior to repair led to overestimation of an engaging lesion. So this was again contested by Korkova et al., who suggested that a true engagement lesion should be looked for after a repair for the anterior labrum is done. This was again substantiated by a study by Park et al., where when the definitions were changed, they evaluated the incidence of engaging lesions, which drastically reduced from 46% with the previous definition to when done post repair, it reduced to only 7%. Again, the problem with this technique as well is that if you are subjecting a repair lesion to extremes of position, it might compromise the repair. So the idea of the track concept is to look for this true engaging lesions. So quickly about how we go about on-track and off-track lesions. So it can be done preferably with CT. So as you can see here, the CT scan is taken and 83% of the glenoid width is taken as the glenoid track. And if any bone loss, if present, is subtracted from this 83% width, and it is considered as a take total length of the glenoid track for that shoulder. And further on, the length of the Hill-Sachs defect is calculated. So from the medialmost point of the rotator cuff footprint to the medialmost point of the defect. So if this medialmost point lies within the glenoid articulation, it is considered an on-track lesion. However, if it lies more medial than to the glenoid defect, than the glenoid rim, either due to defect in the glenoid or due to a larger Hill-Sachs defect, it becomes an off-track lesion. So how do you go about assessing by CT scan? Currently, few studies are demonstrating better efficacy with the use of semi-dynamic MRIs, but they're not commercially available yet everywhere. So 3D CTs is what most commonly followed in most places. So when 3D CT is done, it is preferred to get a scan both the shoulders. And once the CT scans are done, end phase view of the glenoid as shown before should be taken, following which the defect length, the width length ratio or glenoid index or pico method can be used to calculate the defect. The most preferred by Giacomo et al. Is the measurement of contralateral shoulder and the difference between these contralateral shoulder and the injured shoulder to determine the defect length. So once the linear part is done, we move on to the humeral head, where appropriate posterior view of the humeral head is taken and the medial margin of the rotator cuff footprint is marked. And the second line is marked with respect to the length of the glenoid tract as measured. So in this case, without a defect in the glenoid, you can see how the glenoid tract will be much more medial, and the Hill-Sachs defect with respect to the glenoid tract can be measured. So if the Hill-Sachs lies within these two lines, it is an on-track lesion. However, if it overhangs, like say in this case with the defect, when the defect is subtracted with the larger Hill-Sachs, it can overhang the medial border and it becomes a off-track lesion. Point to be noted while dealing with the Hill-Sachs is that you should look for the Hill-Sachs interval, not just the length of the Hill-Sachs. As in this case, you should take the widest part of the Hill-Sachs defect and the bone bridge just medial to the rotator cuff footprint should also be included in measuring the Hill-Sachs interval. So the off-track or on-track is based on the relationship of this Hill-Sachs interval with respect to the glenoid tract. So as you can see, while this might be wrongly calculated just the Hill-Sachs length, we should look for Hill-Sachs interval where it should include the additional bone bridge up to the medial rotator cuff footprint as well. It can also be done arthroscopically. So just similar to CT scans can be using a calibrated probe. So the bare area is taken as the reference point, usually taken from the posterior glenoid rim when it is intact. This is from posterior rim to the posterior, bare area to posterior rim is calculated, and the difference from the anterior rim to the bare area is calculated, and the difference can be used to. This is considered to be a symmetrical, full circle. So if there is any difference, that implies a measurement of a defect. Like say in this case, if there is a posterior radius 15 mm, anterior radius 10 mm, implies there is a defect of 5 mm anteriorly. So this posterior radius, twice of it considered as the entire glenoid width, that becomes D, and the distance from the defect, if calculated, is applied with this formula, like 0.83 times D minus the defect gives the glenoid tract. Similarly, Hill-Sachs width also can be calculated using calibrated probe. As discussed, Hill-Sachs interval should be calculated with the Hill-Sachs width as well as the bony bridge up to the rotator cuff interval. So in this case, it's a huge Hill-Sachs interval. So this with the glenoid tract comes around only 20 mm, whereas Hill-Sachs interval comes around 24 mm. Hence, this will become a off-track lesion. Just to quickly summarize, so first thing is to measure the diameter of the inferior or the glenoid width can be done either arthroscopy or using 3D CT scans. And the width of the anti-bone loss defect should be measured either arthroscopically or any of the techniques described in CT. And the calculation is done by 0.83 times the glenoid width minus the defect. And the Hill-Sachs interval with the sum of Hill-Sachs lesion plus the width of the bone bridge up to the rotator cuff. And the relationship between Hill-Sachs interval and the GT determines whether the lesion is off-track or on-track. Apart from this, there's a new modality which is being brought up, which is the multiplanar CT evaluation, where it is done at CT is done at multiple plane, just like how we go about an MRI. This they find that the radiographically is better suited for tracking the footprint of the rotator cuff and hence better measurement of the glenoid tract. Coming to MRI evaluation, this is the first put forward by Jestoff plus et al. In 2015. He found good accuracy with the measurement of same principles as CT while using an MRI. But they found that it was technically more challenging than when dealing with the CT, in the sense that determining the rotator cuff footprint was particularly difficult when dealing with the infraspinatus. And bone loss measurement was also particularly not very accurate or as convincing as they found in CT. Following it, there's another paper published 2020 by Chalmers et al., where they compare the evaluation with CT and MRI, and also different methods of area measurement, linear and area measurements of the defect. So as you can see here, same defect when compared to the CT as against MRI, the defect seems to be grossly underestimated with the MRI, both on the humeral side as well as on the glenoid side. So their conclusion is that MRI grossly underestimates both glenoid bone loss and the combined loss, and the linear measurements overestimates the loss as compared to area measurements of the defect. So they do not advocate the use of MRI over CT as of now, as of this article in 2020. Another new topic I came across was the dynamic arthroscopic tracking. This is similar to the assessment of tracking on based with the engaging concept published by Deepak Bhatia from Mumbai. So they described dynamic arthroscopic standardized tracking for assessing the hill sacks. So this is what they go about. The patient in position and ready. The post-day portal. The hill sacks is aligned parallel to the glenoid rim and subject to anti-force to look for engagement. So based on this, they suggested whether an on-track lesions can be central or borderline, depending on relationship with the glenoid rim, and off-track lesions one goes beyond the glenoid rim. They suggest that this is more has maximum specificity for off-track lesions, but this is only one study found similar to this. I couldn't find any other studies advocating for this. There seems to be superior in terms of reliability. Again, limitations is anti-translation force is very subjective, and in this study is also done prior to repair, so it might be overestimating the engaging lesions. Another concept which I came across is by article by Kawakami et al. In 2019, where they evaluated the glenoid tract with the different portions of the arm. So as you can see here, so this was the important finding from their study. So I can see where with the further horizontal extension of the arm, the length of the glenoid tract with respect to the glenoid length gradually decreases. So only in 15 degrees extension, we have 83% of the glenoid tract corresponding to the 80 glenoid with corresponding glenoid tract. With further extension, it reduces to only 75%. Similarly, with further abduction at 180 degrees, the glenoid tract width is only 77% of the glenoid tract and not 83%. So coming to the management protocol, this was as advocated by Giacomo et al. In 2014, based on glenoid defect and the tracking of the lesion. However, a new concept is evolved, that is subcritical bone loss. This concept of 25% bone loss is not acceptable by most authors. They feel it is too big to be considered significant. So this was a study by Saha et al. They found the bone loss more than just 13% had poor WASI scores, and hence that should also be considered in the management. Similarly, another study by Shin et al. Found that critical bone loss was greater than 17.3 had dramatically increased rates of recurrence. So they put forward the concept of critical bone loss which following beyond which cause recurrent instability, and subcritical can be considered those no recurrent instability can lead to poor quality of life functionally. So this concept of subcritical bone loss again incorporated in the glenoid tract concept in this paper by Yamamoto et al. In 2019. So where they studied arthroscopic on-track defects and followed up with functional scores, they look for the hill sacks occupancy ratio. So what they did is once the glenoid tract is made and the hill sacks was defined, they divided the on-track lesions into 4 zones: 25% to 25 to 50, 50 to 75, and more 75 to 100. And they found the lesions in the zone 4, that is the very peripheral lesions, had significantly poor functional scores at 2 years follow-up. And the recurrence rate was also higher in lesions in zone 4. So based on this, they put forward this classification that on-track lesions can be further subdivided into a central lesion or peripheral lesion. Central lesion is one which lies within the zone first 3 zones from 0 to 75%, and lesions in zone 4, which can be either to a very medially placed hill sac defect or a hill sac defect with a small glenoid tract due to significant bone loss, will be a peripheral lesion. So this is the strategy they put forward. While a central tract lesion can be treated as conventional on-track lesions, peripheral tract lesions, additionally, the demands of the patients to be considered, and a bony procedure should be done in athletes. Off-track lesions, there's no question, a bony procedure might be indicated. All these concepts were incorporated in this paper with Giacomo et al. In 2022 published in ISACOS. So they went back to their went against their original concept of 20 to 25% bone loss, and this was the recommendation put forward them based on systemic review in 2019, with the bone loss being considered 15%, and based on engagement, non-engagement, scopic or Bankart, scopic or bony procedure was recommended. This is, however, not considering the demands of the patient, and so this is the final algorithm put forward in this paper. So in bipolar bone loss, the bone loss could be considered as up to 15%, following for which soft tissue repair should be adequate. Whether remplissage or not can be decided based on the tracking of the lesion. If more than 20%, no question, be not reconstruction. Again, whether just a latajate or a humeral procedure depends on the tracking of the lesion. If in the gray area between 15-20%, depending on bone fragment present, can be incorporated in the repair. If no fragment or the severe attritional loss, considering the activity, can go for a low demand patient, you can go do soft tissue procedure. For high demand procedure, you do a reconstruction procedure. So when take a message is clean out track concept is fairly around for quite some time and it's being clinically validated and used everywhere. However, it is still further evolving. There are further definitions and finer subsets being put forward with respect to the clean out track concept. So my understanding for any when decision making for any shoulder instability case, you should be aware of how much the bone loss, either any of the parameters, whether defect area or the clean out index or the defect width, tracking of the lesion, whether it's off track or on track, and the activity level of the patients. So as per current literature, the current dictum is less than 15%, soft tissue repair should be adequate. More than 20% defect, clean out reconstruction procedure is mandated. 15 to 20% defects are still in the gray zone and should be decided based on the patient's demands. Thank you, sir.
This concept will still evolve more. In the next 5 years, it's going to evolve more. The reason is now the differentiation is whether to do an arthroscopy or an open procedure, more than a lateral procedure or bone block procedure. Now it's either arthroscopy or open. Now with the advent of arthroscopic latajate, we want to either just a bone block procedure is enough or to supplement it with a lateral repair. That's the way they're going to see it. And the advent of the scapular spine, which is available as a autologous bone graft, and the availability of special instrumentation, I think improving the bone adhesion with the bone block procedure and concomitantly repairing the labrum will add up to the value of the surgical technique and the outcome. There are people who have started doing this methodology, and maybe in another 3 to 5 years, we'll come up with a new outcome measures, which is going to completely change the way we think about this clean out tracking concept and how much percentage is considered significant. So at present, it is 13.5% to convert it to a bony procedure in a high demand patient, whereas 23%, 24% is good enough for a low demand patient. So let's keep it like this. I think it will change in the next 5 years.
Yes, sir.
And if you don't have any questions, we will end the session. Sir, can you close the session, sir?
Thank you. Excellent, excellent presentations.
Thank you. Good night.
Good night. Thank you.
Thank you.
Thank you.